Here we find ourselves again. We're going to this week talk about drug exam number 13. We're continuing our discussion on cardiac arrhythmic drugs, and we have just 4 today, so there won't be a lot of me talking in this one. The first thing I do want to talk about, though, is action potential. And action potential is something that involves the cardiac cells depolarizing and then repolarizing. When you think about the heart depolarizing, con, con, um, beating or constricting, I want you to think about a toilet that's flushed. When you have a toilet that's been flushed, all the water and contents have left the toilet. Now, in most home normal toilets, you can't immediately flush it again because the bowl has to refill. And the cardiac cells are kind of the same way. It takes time after that initial depolarization for the cell to be ready to depolarize again as those electrolytes move in and out of the cellular membrane. So when we talk about dysrhythmic drugs, what we're trying to do is we're trying to either slow down or speed up those molecules coming in and out of the cellular membrane, and that forces the action potential to be influenced. The first medication we're going to talk about is mag sulfate. This is like the third time we've talked about mag sulfate in this series of videos. Now, in this situation in cardiac, we're going to talk about giving mag sulfate for something called torsades, torsades de pointes. And what it is a polymorphic VTAC. And now that is a very specific thing that usually is only caused by 2 problems. And one of the problems is low magnesium. The other is a prolonged QT syndrome. If you have somebody that has a naturally long QT syndrome, if we give them something like Zofran or Phenergan, something that causes the further extension of that QT segment, we can throw them into torsades. Now, torsades can have a pulse or it cannot have a pulse, just like VTAC. VTAC we know can have a pulse and it might not have a pulse. So whenever we see VTAC, the first thing we have to do is check a pulse. Now, just because we have this medication doesn't mean that we're not going to intervene electrically by defibrillation. If we are presented with polymorphic VTAC with no pulse, we're going to defibrillate that immediately. Remember, if we see a shockable rhythm and we have stopped, we immediately resume CPR while we charge the monitor, and then we defibrillate it once we have cleared our patient. So this is a medication that is going to be given after we provided the electricity, and we are going to try to get that polymorphic VTAC or torsades stopped. Typically, the dose is 1 to 2 grams given over 5 to 60 minutes. There's a lot of variety in the protocols that you might be presented with involving this. Some of the protocols even say 1 to 2 grams giving IV push immediately during cardiac arrest. Others say it's an infusion that's given over a long period of time. So I would encourage you to look at your local protocols when you get to wherever you're going to be working and learn about the appropriate protocol to follow them. But in our class, we're going to stick with the dosage of 1 to 2 grams given over 5 to 60 minutes. The next medication we're going to talk about is procainamide. Procainamide is kind of a medication that's been around forever. Not a lot of places carry it anymore, but we can give it to patients that have AFib with RVR. It's a 20 milligram per minute infusion. It should not be given if the patient has prolonged QT syndrome or torsades or high degree heart blocks, 2nd and 3rd degree heart blocks, or or they have a tricyclic antidepressant overdose. The only time we would give it is typically with AFib with RVR, and it would be a 20 milligrams per minute infusion, a drip. Next medication we're going to talk about is verapamil. Verapamil is also known as isopatin, and the dosage for that is 2.5 to 5 milligrams given over 2 minutes in a push. And verapamil is a calcium channel blocker, and you will see it given as an alternative to diltiazem or cardizem in some situations. Typically what happens is we hope agencies will carry cardizem or diltiazem, but it has to be refrigerated. So if the agency does not have the ability to carry refrigerated medications, then typically what calcium channel blocker they will carry would be verapamil. And it's given for a flutter, AFib with rapid RVR, or reentry SVTs. The last one we're going to give potentially or talk about in this lecture is epinephrine. Epinephrine is, remember, it's an endogenous hormone. It is adrenaline. It is the same thing that our body produces in the adrenal glands. And in this situation, we would be using it as a pressor. And we will talk in class about how we mix this medication, but it's given in pushes, and through mixing of your cardiac arrest epinephrine vial, we can dilute it down to where we can have 10 mics in per milliliter and titrate it to the patient's pressure. And I want you to think about this as manipulating that sympathetic nervous system. We're just giving a little boost. So if the heart rate's a little low, the pressure's a little low, and we want to give them something to get that up quickly, we will use that 10 to 20 mics 10 to 20 mics of epi pushes every 5 minutes or so, or however long you need, but you would titrate it to your effect, and it just kind of gives that sympathetic nervous system a little bump, a little kick to kind of kick up that heart rate, to positive inotropic effect, positive conotropic effect, and that it also causes that vasoconstriction that we're looking for. And it is kind of a nice, quick way of getting someone's pressure up. And the good thing is that it is an endogenous hormone, so the body is used to it as well. The duration of it is very quick, immediate, and it only lasts for a few minutes. So this will be something, if you have a long transport, you might want to consider other alternatives, your more traditional pressors, your Levofeds, those types of things. But if you're a few minutes out and you need to do something to get the patient's pressure up a little bit, you can give them a little push dose pressor, 10 micrograms of epinephrine to turn things up a little bit, if you know what I mean, by influencing that sympathetic nervous system. So that's all we have for this week. We will continue on next week with our cardiac arrest meds. And as always, if you have any questions, feel free to reach out to your instructor, and we will see you next time.